A good day to everybody. My name is Dr. Lucinda and I'm here to give a brief lecture on common conditions in hair and nails that we see in the pediatric dermatology population. So, a quick background, kids are not just little people, they actually provide diagnostic and therapeutic challenges on their own. They can have distinct presentation and characteristics different from the adult population. Usually the parents are worried that the hair and nails may reflect systemic diseases and hence they bring the little kids to see us. And the child himself is usually unaware of the fuss. So looking at hair conditions, we will briefly go through alopecia areata, tinea capitis and trichotillomania. These are the three more common conditions that we usually see in children. So for alopecia areata, it is a chronic immune-mediated disorder. It is non-scarring and can affect all hair-bearing areas. That includes the scalp, eyebrows, eyelashes, the beard, armpits, or the limbs. Predisposition-wise, there is a genetic link. Stress has also been known to cause alopecia areata. Infections as well as vaccinations can sometimes act as triggers. So clinically, we see a smooth, circular, discrete area of complete hair loss. So in this picture, you've noticed that this patient has a couple of spots. So looking at the occipital area, there is a well-demarcated, discrete patch of hair loss. And we know that it's non-scarring because on closer look, you can see the presence of hair follicles as well. Okay, exclamation point hairs. If you look at the picture here, you should be able to find short broken hairs for which the proximal end of the hair is narrower than the distal end. And this is common and a pathognomonic finding of alopecia areata. It is usually found at the edges of the expanding patches. It can be extracted with minimal traction. When we talk about prognosis and management in alopecia areata, we need to consider a few key points. The first is that spontaneous hair regrowth is common, meaning that without treatments, they can get their hair back. And then recurrences can occur. So even if they do get their hair back, they may then lose it again. And hence treatment is not mandatory, especially in the pediatric population. We need to consider the parents' and patients' preferences and the risks and benefits of treatment before suggesting. So commonly, systemic glucocorticosteroids can also be given as a temporary measure to slow the hair loss in patients if they have rapidly progressive, extensive hair loss. So if the alopecia areata is limited, we can consider topical corticosteroids. We can also consider intralesional corticosteroids. Microneedles as such. So these are 1 cm or 2 cm circular patch with the microneedles at the bottom and into the alopecia areata area. You don't feel the pain of the needles, you're just pressing on the microneedles. So this can be an option in children, especially if they are having a needle phobia. Minoxidil can also be used to encourage hair growth. In extensive hair loss, we can consider topical therapy. Diaphen cyclopropanol, DCP, or squaric can be used. What we do in topical immunotherapy, use the potent contact allergen to stimulate an immune response. And this immune response then inhibits the pathological immune response via antigenic competition. And this will affect the alopecia areata and hopefully hair can then grow back. The other option is also PUVA, pain tolerant and ultraviolet A. So we will go through some of the cases and manage. In this case 1 is an 8-year-old Chinese boy with active patchy hair loss, and the hair pull test is positive. So you can see that there are patchy hair loss, well-demarcated, discrete alopecia patches, non-scarring. You can see the follicles within already. So because it was active, meaning that he was losing a lot of hair on a daily basis, he was given oral steroids initially to slow the rate of hair loss. And then because of the large areas involved, and he's a child, usually injection steroids difficult since the kids don't allow needles near them. He was started on DCP, so topical immunotherapy, and that helped. Case 2 is a 12-year-old Indian girl initially seen for localized alopecia areata. It resolved with intralesional steroids and topical 2% minoxidil. However, it recurred 3 years later. And as you can see, initially it was a localized AA and now it's kind of alopecia totalis, which means the entire scalp is affected. Alopecia universalis is if the other areas are affected, such as the eyebrows, armpits, or pubic areas. She was given oral prednisone over a few months to slow the rate of hair loss. And because the large areas of alopecia areata, you can't give topical or injectional steroids. So we started immunotherapy with DCP. So we usually go up on the percentages gradually. But she failed to respond over 2 years, and so we stopped treatments. She returned for a review after 4 years, and this is 6 years of alopecia totalis in total, and we trialed her on tofacitinib for 15 months. Tofacitinib is a Janus kinase 1 and 3 inhibitor. It's currently being used for alopecia areata with quite a good response. Common adverse reactions include upper respiratory tract infections, headache, diarrhea, or nasopharyngitis. So for her, after 15 months, she's gotten all her hair back. Of course, the challenge in this case is to see if this could be maintained. So of course, we will wean off tofacitinib and we will have to watch to see if the hair growth is maintained or if it's lost again, needing a restart of the tofacitinib. And we've also published a paper for alopecia areata in patients treated with pain tolerant and ultraviolet A. So we've had 10 patients over the past 10 years, and as you can see in the picture, so before treatment, and then when we stopped the PUVA, they had a relapse, and when we restarted PUVA again, the hair grew back quite nicely. So there's significant hair growth seen in 6 out of 10 patients. Briefly, people have also considered using immunosuppressants such as methotrexate, cyclosporin, sulfasalazine, or even platelet-rich plasma, which is investigational currently. These need a lot of discussion with parents because of the potential side effects, and usually we don't tend to need to use this in the little kids, given that we have other options as discussed before. Okay, moving on to tinea capitis. So tinea capitis is actually a fungal infection. It presents with pruritic scaling areas of hair loss. Usually, Trichophyton and Microsporum species are the ones causing the fungal infection, and it's usually contracted from another human or animal through direct contact. So clinically, you can get single or multiple scaly patches with alopecia and patches of alopecia with black dots at the follicular orifices. A cheiron is actually an inflammatory plaque with pustules, crusting, and drainage. So for tinea capitis, usually there is no permanent scarring alopecia. However, this is not the case in cheiron. Because of the severe inflammation, the children can end up with permanent scarring. This picture that you have seen, you can see that there is a demarcation. It's erythematous and swollen. You can see that there are pustules seen here. So this is actually a cheiron forming already. For tinea capitis, a high index of suspicion is required. If you don't suspect it, you may miss it. So it's particularly suspicious if there are cervical lymphadenopathy present. When we examine with the dermatoscope or a magnifying glass, you can see that the alopecic patches actually have scales or black dots. A fungal scrape and culture is usually helpful. However, just a note, if it's to diagnose tinea capitis, we would usually pull the hairs out and then send the root for examination on a microscope as well as culture. If it's just a scrape, we may miss the fungus. And of course, use of a Wood's lamp. If it's fluorescent green-yellow, it might suggest a Microsporum. If it's fluorescent faint blue, then Trichophyton. Management-wise, for fungal infection of the scalp, oral antifungals are usually preferred because the topical antifungals are unlikely to be effective, mainly because of the inadequate penetration of hair follicles and it may miss sites of subclinical infections. So the FDA-approved oral agents would be gracefovin and terbinafine. Fluconazole and itraconazole are effective as well, but less frequently used. And as an adjunct, we would always give patients an antifungal shampoos for the patient as well as the close contacts, so family members. And of course, remind the family to disinfect their combs so that they don't perpetually pass the infection around. So in case a boy presented with hair loss and cervical lymphadenopathy, and on close look, you can see that it's actually a well-demarcated alopecia patch. There seems to be some loss of follicles already, so you wonder if this is progressing to a scarring alopecia. The culture was positive for canis, and on history, he actually had contact with a cat that was sick. And this boy was treated with oral crucifovin and cleared the fungal infections quite nicely. But as you have noticed, because of the earlier scarring, the patch may be permanent. There may not be any further hair growth noted. In case 2, it's a 5-month-old Malay boy with a history of hair, and he actually presented with pus about 3 months of age. And the parents have tried topical steroids, potassium permanganate washes, gentamicin cream, fusidic acid, as well as oral caprolactin with no major improvements, and hence they came by. Otherwise, well, an active boy has a cat at home and his siblings are not affected. So a large area of scarring alopecia, scarring because you can hardly see the follicles already. You can see a lot of pustules, a lot of crusting, and when a lot of erythema and scaling. And when we use the Woods lamp, it actually fluorescent yellow-green. So culture was positive for microsporum. Treatment-wise, he was given crucifovin at first, but persistent infection was noted on repeated skipping cultures, and so switched to terbinafine. Responded nicely, fungal infection cleared. He had a very mild transaminitis during treatment, which resolved upon cessation of the oral antifungals. Moving on to trichotillomania. It's a hair pulling disorder. It's a mental disorder that involves recurrent, irresistible urges to pull out the hair from the scalp, eyebrows, or other areas of the body. And the areas of alopecia may have irregular or bizarre shapes. As you noticed in this patient, a very bizarre looking alopecia patch. Generally, this is a non-scarring disorder, so you can always see follicles on high magnification. Trichotillomania requires a high index of suspicion and directed questioning. Sometimes you may not be able to get the questions on the first visit. It may require a couple of visits to gain rapport with the patient and parents, and for the parents to observe the kid at home before the questions can be answered. Generally, we can try and ask if the kids feel a sense of tension before they pull, or if they try to resist pulling. If they feel a sense of pleasure after the hair is pulled out. If the parents notice that there are specific rituals that accompany hair pulling, for example, the kid may twirl the hair a couple of times before pulling. Notice if the kid likes to bite or chew the hair. And notice if there is a significant distress or problems at work or school or social situations that may be a trigger for the hair pulling. Management-wise, because this is a psychological problem, most of the management would focus on behavioral modifications, and this can be done with a psychiatrist or a psychologist. A lot of coping mechanisms can be introduced to reduce the hair pulling mechanism. So running through, in case 1, this is a 12-year-old girl, and she presents with loss of her lateral eyebrows. If you notice, just a bit more sparse over here. Again, non-scarring because you can still see the presence of follicles. And on thorough questioning, then she admits to plucking her hairs due to stress. And in case 2, in this boy, 10 years old, he complains of a scalp itch over the past few months. Some of the kids will say that they are pulling hairs because the scalp is itchy. But if you examine the scalp is usually not a problem, meaning that you don't see scalp redness or flakes. And you can see over here there is a patch of alopecia. It's a little bit of a bizarre looking shape, and the follicles are still present. On close examination, hairs broken are of varying lengths, hair suggestive of trichotillomania. So you can see that the hair lengths are usually different, and you can note that there are many regrowing hairs as well.